Good afternoon, everybody. My name is Lucy Kani. I'm the moderator this afternoon. We are very sorry for the delay in starting, and we are ready to start now. And this afternoon, we are going to have 3 presenters who are going to take us through the webinar this afternoon. And the first one is Christopher Kibiwot, who has OGW, which stands for Order of Grand Warrior, and he's the lead coordinator at the Kenyatta National Hospital Infection Prevention and Control Unit. He's going to take us through infection prevention and control practices in a changing world. We can put all our questions, all our comments in our chat, and we are going to go through them. And as we go through the presentations, then we shall have our questions answered at the end of every presentation. After Kibiwot, we shall have 2 other presenters, Sylvester Wenda, who is also an IPC practitioner attached to Infection Prevention and Control, Kenyatta National Hospital from the University of Nairobi with the MAP AMR project. Our third presenter is Roger Square, who is a BSN from Kenyatta University, registered nurse, nursing officer at the Homa Bay County Teaching and Referral Hospital. We are ready. So our first presenter this afternoon is Christopher Kibiwot. Welcome, Christopher Kibiwot. Thank you.
So good afternoon, all. I also take this opportunity to welcome all of us to this wonderful presentation, being the International IPC Week. So this presentation is actually on the mark. So I'm going to handle some of the presentation, and my colleague Wendy is going to handle the other. And as Kanye said, we have somebody from Homa Bay Hospital, and we want to hear that experience in a level 4 health facility. So today we're going to talk about infection prevention control practices in a changing world. So indeed, this is a changing world, and we need to align ourselves with what is happening across the world as infection control practitioners. So IPC, as we know, has some objectives in every healthcare setup, and it is a requirement for every healthcare facility in the country, if not worldwide, to have an IPC program. And more often than not, you'll find hospitals have IPC programs, but they don't practice IPC, or they don't have an active IPC unit. So in KNH, at least we are able to have all that. So objectives of IPC is always to promote the provision of quality healthcare. It also promotes patient safety, and we can add also staff safety. And IPC helps also to reduce occupational hazards associated with the healthcare. That goes to the healthcare workers, because we don't want an healthcare worker to have an infection when they were coming to take care of a patient. Why the interest in IPC? We have issues because we realize that the world population has been increasing in size. And as we know, all of us, we are running out of antibiotics. So that is why IPC is very key when it comes to management of every patient in our health settings. Then we have this issue, which is worldwide, resistance to antimicrobial agents. This is what the world has been grappling with for a long time. We have resistance to most of even the latest antimicrobial agents. So the only solution that we can be looking at, and the easiest option, is actually to perform IPC. Then another aspect is that that one is linked to the other one, inappropriate use of antimicrobial agents. We have a problem with over-the-counter prescriptions, where somebody can just go to the chemist and ask for a particular drug. And actually, most of it could be even as far as the fourth line, which is also working so hard against the antimicrobial agents that we have in the market. So we have the changing lifestyle. We can also contend that the world these days is changing. In fact, we are moving from the communicable diseases to lifestyle-related diseases. And you know, with lifestyle-related diseases comes also issues with diabetes, We have cancer, which are a result of maybe our modern lifestyle. And with these challenges, we really need to practice IPC so that we take care of these new diseases. They are usually called new diseases. Then we continue. So we continue with the concern of IPC. We have also an issue with the spread of hospital-acquired infection from staff as they move from one patient to another. This is actually our day-to-day practices in all the clinical settings. We have also medical procedures that bypasses the body's natural protective barrier. Here, we usually insist on what we call the care bundles, so that whenever we do any invasive procedure, we have to follow a certain protocol to make sure that we don't spread infection as healthcare workers to the patients. So that one care bundle, we'll talk about it sometime later. So we have the new adoption to the IPC, because you remember this topic is about IPC in the changing world. So infection prevention control is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers. Remember, some time back, we were talking about only the patients, but these days we have covered also the healthcare workers, because as you all know, if the healthcare worker is not safe, the patient also cannot be safe. So that's why it is very important that we adapt to the changing situation in the world. It is a subset of an epidemiology. Actually, when you talk about IPC, we cannot rule out epidemiology, because when you talk about IPC, it is auditing processes, investigating cases, and following it up. So it is actually intertwined with epidemiology. And I'm happy to say that many IPC practitioners these days are also taking the epidemiology route, because that is the only way you can address issues scientifically, not only by analyzing using word of mouth. But it also serves as an essential function in infectious diseases, social science, and global health. When we put in social science, it's now we talk about IPC in the hospital, and we also extend to the society where these patients are coming from. So that's why IPC is supposed to be hospital, and then it has to have an arm reaching the public. So effective IPC is a public health issue that is fundamental in patient safety and health system strengthening. You cannot have an hospital which has a quality healthcare without an IPC unit, because so long as an IPC unit is available, everybody rest assured that they are safe. When they go to that hospital, they are sure that they will not emerge with a new disease. So epidemics, including the 2013 Ebola virus outbreak, and there have been several outbreaks also from that time, from 2013, 2016, and I think there was one last year in 2022, somewhere in Uganda. And pandemics of international concern, for example, the 2009 flu pandemic that was in the Arabic countries, and the latest now, the coronavirus disease, are rooted in effective measures, IPC measures. So if we don't perform effective IPC measures, we will be at a loss to handle these epidemics. So that's why I talked about IPC being intertwined with epidemiology, because when we identify a disease, we have to institute IPC measures immediately to make sure that it does not spread to the healthcare workers, it does not spread to the patients, and it does not even spread between the patients. A guiding principle on WHO core components of IPC is that access to healthcare services designed and managed to minimize the risks of avoidable hospital-acquired infections, which is abbreviated always as HAI, for patients and healthcare workers is a basic human right. Now, as I said, in the changing world, these days, IPC has become almost a human right, and that is according to WHO, because we don't want a patient to contract another disease when they came into the hospital with a different disease. So it is very crucial that IPC practice is rampant in all healthcare settings. So strengthening global IPC is essential to combat hospital-acquired infection, antimicrobial resistance, and to respond to disease outbreaks. That one I also clarified when I talked about epidemiology linking with infection prevention and control. A study published in 2021 looked at the WHO core components, showed most countries have IPC programs. That is very true. Most countries have an IPC program. However, few have set aside the necessary resources to support the programs. Now that is the question. You may have the programs, but now if you don't have the resources, if you have not allocated the resources, that one goes to the county hospitals, that one goes to the smaller hospitals. If you have not set up resources to make sure that you support the IPC programs, how are we going to prevent infection from reaching other patients? So there is need to move from the planning stage into the implementation and monitoring stages, particularly in the third world countries where IPC is really needed because of the limited resources. So actually, that is actually an outlook of what IPC is now in the changing world. So we can now narrow down and come to the hospital setting. And you can see that diagram. It shows us where all the organisms could be. Actually, those are just a few areas, but they are all over. If proper IPC techniques are not followed, if proper decontamination is not followed, and if the IPC program is not working in the healthcare system, there is a way of breaking the chain. And always, as IPC we say, the two ways of handling any infection, from getting from one patient to the other or patient to staff or staff to patient, is just to know two things. The various ways infection can be transmitted. If you know that a certain condition is transmitted in a certain manner, it is easier to see how to control it. So the two key factors which should be considered is the various ways infection can be transmitted, and number two, the ways the infection chain can be broken. I can give an example of the COVID-19. When it came, there was a lot of worries worldwide. People did not know how this COVID-19 is transmitted. But as soon as we understood that it was a problem, it became now easier to control the COVID-19. And that is why the mortalities did not rise as it was expected. At this juncture, I think I'm going to hand over to my colleague, Sylvester, to continue with what we call the IPC standard precautions. Welcome, Sylvester. I will join you later when we talk about surveillance.
Thank you so much, Mr. Kibiwott. Basically, I've really discussed it well in the opening of the introduction of the IPC. And it's very important to discuss about IPC because this is one of the areas whereby hospital healthcare-associated infections are really reduced at a rate of 80% when we have the IPC measures put in place. So straight, I'm going to handle about standard precautions, whereby we normally have 10, but in our list, basically, you see we have 12 because we are IPC persons. So basically, you'll see we have added some there. So we'll start with hand hygiene. Then from there, we shall move to personal protective equipment, that is PPEs. Then patient placement and stroke isolation. Then we'll go to instrument processing. Then cough etiquette, environmental hygiene, surveillance, outbreak management, waste management, injection safety. Then we finally do the occupational health. So let's start with IPC control. So here you can see something called the hierarchy of controls. So in hierarchy of controls, basically you're going to discuss about this chain here, this breaking the chain of infection. But basically we are going to discuss it in a very different way. How are we going to discuss it in? This chain of infection, basically we have discussed it so many years, so many days, time comes, time goes. But now we have a new way of how can we handle it. So we are going to handle it using this hierarchy of control, whereby we have elimination. What do we do in elimination? This is the physical removal of the hazards. What are these physical removal of the hazards? The elimination, basically removal of hazards at a source. For example, we have stop using a toxic chemical. That now you don't expose the chemical to the patient. So that is now you are eliminating it. No exposure can occur. So you do elimination. Another point is about substitution. How do we do the substitution? We try to replace the hazards. For example, if a patient can take the oral medications, instead of giving a patient injections, the IVs, basically the right thing we can do, let's substitute the IVs to the oral drugs. This will reduce the rate at which the patient will get the central line associated infection, central line blood associated infection. So let's talk about it. Substitution, use of a safer alternatives, or oral instead of injectables to reduce needle stick injury. When considering a substitute, it is important to compare the potential new risks of substitute to the original risks, because now we say that everything that we do has a risk. So how do we compare the risk? If the risk of substitution is very low, it is better we go with that risk. Another thing that we can talk about substitution. If a patient has a central line, which has 2 lumens or 3 lumens, it is basically good if the patient is receiving just the drugs, the IV drugs. It's better you retain the 1 lumen than having the 3 lumens or the 2 lumens, so that you reduce the rate of infection or the infection entry. We can also talk about elimination and substitution can be the most difficult actions to adopt into existing process. These methods are best used at the design or development stage of a work process, place, or a tool. At a development stage, elimination and substitution may be the simplest and cheapest options. So at the development stage, basically elimination and substitution may be the simplest and cheapest options. Why am I saying this? Because if you look at the cost of treating a patient who have bloodstream infection, yeah, of a HAI, like now let's say about Klebsiella. Managing a Klebsiella may be very, very expensive. But now, if we do the elimination and substitution, we reduce the number of lumens, the CVC lumens, or we substitute the condom, the catheter in the catheters with the diaper. It is better. Let's talk about engineering controls. Engineering controls. Let's come back to our engineering controls hierarchy. Let's look at it. It's isolate people from the hazards. What about the explanation? This reduces or prevent hazards from coming into contact with. Can include modifying equipment or the workspace using protective barriers and ventilation. IPC is very core when it comes to now building construction assessment, whereby we have to know what are the risks of a building. If the building is being constructed, what is the purpose of that building? Where do we put the hand washing places, points? Where do we put the ventilation points? What are the spaces that we need in a unit? How many beds can that unit accommodate? What is the distance between one bed to another? Those are now engineering controls, so that now we control whatever can come in. Administrative controls is one of the next one. Establish work practices that reduce duration, frequency, or intensity of exposure to hazard. This may include work process training. So we have continuous training to the healthcare workers. Nurse who is in the unit, we do continuous training, whereby we take them to the CMEs, we teach them on antimicrobial stewardship, and also teach them on the new infections that are coming, the emerging and re-emerging infections, new management of a disease. Also job rotation. If a person works in one place for a long time, it becomes tiresome and also boring. So if the person can be rotated from one place to another, it can also be helped so much on infection prevention and control. Ensuring adequate rest breaks. So if a medic, basically, if some medics work like more than 10 to 18 hours, basically, if this person basically is tired, so if you do a procedure right now, the next hour you get to another procedure. So if you conduct procedures like a long period of time, you even become tired. And now the IPC measures that are supposed to be put in place may not be effective much than from the beginning. So it will go as they reduce. So also we can do the limiting access to hazardous areas or machines. So basically, this is now you prevent those people are not required, the healthcare workers who are not required to get into, for example, isolation places, they should not be going there. That now you put that place to be isolated areas. Also now, hazardous areas also can be the lab machines. Those people are not supposed to be there, are not supposed to be operating that lab, that machine in that lab should not be there. Also adjusting the line of speeds. Adjusting the line of speeds, which means if you have a high turnover of patients moving to theater, like you do operations of like 10 to 20 patients within a span of from morning to evening, basically you can try and reduce the number to a number that is manageable, that you can control very well. Let's continue about PPEs. Personal protective equipment is equivalent is a equipment worn to minimize exposure to workplace hazards. So PPEs basically realize that some of the medics, some of the healthcare workers use them wrongly, because PPEs you're supposed to select PPEs according to the use. Yeah. For example, if you're going to handle a patient who has COVID-19, which type of PPEs are you supposed to put? Are you supposed to be putting gumboots? Are you supposed to be putting the gown? Are you supposed to be putting the headgears? Are you supposed to be putting the? If you put the gowns and the headgears, will not help you. So that patient, you only need a mask. Are we together? Then also inspection and replacement of damaged or worn out PPEs. So like now, if you have a dust coat which is torn, you can change it. You can also change your mask. You can change your gumboots. Then also employee training. We train the employees. For example, that one I can say, if the hospital hires new staff for the housekeeping staff, basically during the induction, basically the hospital should have a trend of training them, doing an induction training on IPC measures. Also the students, if you can capture the students when they are coming from these institutions to the hospital for training, for their attachments, for their internship, we can train them before they get into the hospital. Do not rely on PPE alone to control hazards when other effective control options are available. So if you have other options for controlling the hazards, please use them instead of using the PPEs. The PPE can be effective, but only when workers use it correctly and consistently. I've just talked about a patient who has COVID-19. So if you wear headgears, you're not even using it appropriately, or you're not using the correct use of it. So you have to use the correct gear correctly and consistently. You can also, the PPEs might seem to be less expensive than other controls, but can be costly over time. So when you use PPEs may be like in a mask, you see a mask is very, very cheap. It's not expensive. But now when you use it time and time, each and every day you need a mask, it becomes costly, because now there is a high demand of the PPEs. So the higher the demand, the higher the price. So hand hygiene. Basically, this hand hygiene is one of the most important things that a hospital healthcare worker should normally do. In IPC, basically, we normally say, if you can raise your hands and see your nails behind your hands, basically that means that there is something wrong somewhere. So your nails should always be shorter and clean. So the hand hygiene is one of the simplest and cheapest ways on preventive measures, and it prevents 80% of healthcare associated infections. Follow the correct techniques and the moments. So moments, we have 5 moments of hand hygiene, 2 before moments and 3 after moments. 2 before moments are before touching a patient and before a septic or clean procedure. What about the after moments? After moments, we have after touching a patient, after body fluid exposure, and after touching the patient's surrounding. If you do audits, if we do audits, basically, you realize that even if you do your self-auditing, you realize that healthcare workers basically clean their hands after touching the patient, mostly. So what happens before touching the patient? Remember, when you are washing your hands, you're protecting the patient from getting infections, and also you from getting infections from the patient. But when you're using PPEs, you're protecting yourself from getting the infections from the patient. So basically, hand hygiene is one of the most important ways of doing preventing the infections. So here is a chart that shows the 5 movements of hand hygiene that protects the patient and you. One, before touching a patient, before procedure, then after exposure to a body fluid or risk, then after touching a patient, then after touching a patient's surrounding. PPEs, basically you can choose the type of PPEs. You can see the pictures here. What is the masks are there all over. You can see the headgears, Google. You can see the gloves here, and also you can see some hanging gowns along the corridor near the door. So basically, what does that show you? Yeah? So then we have patient placement. Consider risk of transmission before patient is assigned to a room or a ward, and appropriately. So basically, if we say about the patient placement, we can talk about cohorting, we can talk about isolation. So what are some of the things that you look on when you're cohorting a patient or you're isolating a patient? So when you're isolating a patient, basically, you have to consider the risk of transmissions. Yeah. Then now you isolate the patient. And also when you isolate the patient, you should inform the team members who are working in that unit, the primary health caregivers, so that now you reduce the anxiety rate, because basically when you just isolate a patient and you expect other people to get to that room and you have not informed them, basically people will have fears. So no one will be ready to go to that unit. Basically, you'll tell someone will say, no, yeah, I'm not going there because I don't know what is there. But when you tell them, they're informed, basically, they'll be there. So what are the priorities we can check on? We can check on infectious diseases, then draining wounds or incontinence, then infants, patients with altered mental status, immunosuppressed or open wounds. Yeah, so those are some of the factors that we should consider when we're placing a patient or we are isolating a patient. When you're cohorting a patient, basically you come up with patients with the same symptoms. You cohort them at the same place. Also, when you have a unit which does not have isolation centers, you can do barrier nursing, whereby you can place a patient in the corner and nurse the patient last. Let's go to instrument processing, whereby we have cleaning, disinfection, and sterilization. So how do we do the cleaning? Cleaning is physical removal of soil and organic material, including some bacteria and viruses. It is just removal of soil and organic material. Remember, we are just removing. It doesn't destroy, it doesn't kill. It's just a matter of removing. That is disinfection. Disinfection kills or destroys most disease-producing microorganisms, but rarely kills all spores. So basically, disinfection rarely kills all spores. It doesn't kill much of it. So basically, it works with killing and destroying most of the disease-producing microorganisms. But on the spores, we'll move it to the next level, whereby we have sterilization. Sterilization destroys all forms of microbial life, including bacteria, viruses, spores, and fungi. So this basically also gives me back to the environmental cleaning. How do we do the environmental cleaning? Do we have the 3-bucket system, whereby we have a soap and water? Then we have jig. After jig, we have clean water. How frequent do we do it? What is the dilution content of it? What do you use? What are some of the disinfectants you use? Because you realize some are using detergents in terms of disinfectants. So also you have to be very careful when you're doing that. Like now, endozyme. Endozyme basically, most of the people use them as disinfectant, but endozyme is just a detergent. So endozyme is a detergent, it's not a disinfectant. You can see it from this picture. So when you move to most of the units, some people they are still not aware that endozyme is a detergent, so they use it as a disinfectant. Then you can see how things are placed here, how the ambu bag are placed. In the corner, you can see how the dustbins are. Basically, the color coding, you should be coded well, waste segregation. You can see how it is color coded. It's very open. Don't know what is being soaked there. So this is not the right thing that is supposed to be done. Basically, whatever is supposed to be done must be according to the standards, the right standard. Environmental hygiene. A clean environment forms the basis of infection control practices. Purpose of cleaning is to remove visible dirt, the level of the microorganism, reduce the level of microorganisms, and to limit the spread of pathogens. Surface disinfection is recommended for high-touch areas. So do you really understand the high-touch areas? Nurse's desk is a high-touch area. Why? Almost everyone, after reviewing a patient, before reviewing a patient, when they come from other units, they normally touch that area. All the files that a patient, because file is a patient environment, they normally come and place them on that place. That is a high-touch area. The telephone is also a high-touch area. Now, when you go to the bed rails, the drip stands, you also check on the monitors. Those are high-touch areas. Look at now waste segregation, the color coding. You can see the first picture has a black bin, red bin, yellow bin. Then we have a sharp box. Then the second picture is, you can see how it is being, how it is. This is not the right one. The second picture is not the right one. The first picture is what is right. It is color coded. And if you see the bin, the black bin has a black liner. Red bin has a red liner. Then the yellow bin has a yellow liner. Then they have been coded and labeled very well. So you can see this picture here. It shows high-touch areas of a patient, of a unit. You can see the monitor somewhere here. You can see the patient desk. You can see the patient table. You can see the oxygen point at the wall there. You can also see the bed rails. You can see somewhere here we have the chair in that room. So those are high-touch areas. Another high-touch area is also the sink. And also that is not shown here is about the doorknob is also one of the high-touch areas, and the switch, and the telephone. Those are some of the high-touch areas. So how do we deal with injection safety? Discard sharps only in sharp container, please. You can see this sharp box here. It is not the right one. Basically, the sharp box should be full until 3/4. It should not pass 3/4. So it should not be full as this one. These are risk to the healthcare provider, and also to the risk of someone who is going to support staff who is going to collect them and take them to the incineration center, the waste segregation, the waste disposal area. Also, you see this one. We have ampules here with the needles inside them. These are very high risk. So if you have withdrawn your drug, basically the best thing you can do is to remove the needle and discard that. Never fill a sharp container more than 3/4 full. Do not recap a needle before disposal. Do not manipulate needles before disposal. And also never leave sharps unattended to, or disposed or unattended to. That means you dispose immediately. So you can walk to a ward. Basically, you can walk to a ward and realize that a certain healthcare practitioner, maybe a doctor, maybe a phlebotomist, maybe nurse was doing doing a sample collection, and they forget the sharp on a patient's bed. Basically, that shows you that was a wrong procedure you are using. Because when you're doing a procedure, you're supposed to be having a trolley, and also the kidney dish which you are supposed to be holding your equipment. So report all injuries with sharps. So also this one can also give you, how do you report sharp injuries in a hospital? Do you have a format? Do you have a channel? If today you are pricked with, you have a needle prick, where do you move to? Do you go to the administration? Do you start from the unit, or do you keep quiet? Those are some of the things that you're supposed to know. You're supposed to be moving from this place to another place. Then from there, which system are you moving to? You're supposed to be checked the same day, the same hour, or there's a period of time that is being there. So basically, you have to report immediately to the person who is in charge of the unit. Then now they have to note it down, then they move to the next level. So linen handling, how do you handle your linen? Prevent clean linen from becoming contaminated. So linen should be put in a closed room, in a closed cupboard, whereby now you should not move them, you should not be exposed so much. All these are very clean. Then prevent the used or soil linen from contaminating patients, staff, and the environment, and other linens. So if your unit, you have all the linens which are soiled, you place them on a floor, which means that is a high risk of infection, of spreading infection. So you can see this one, this is very wrong that is being done here. These are poor linen handling. You can see where the linens are on the floor. You can see even how these things are put here. You can even see the sanction machine, the sanction bottle here, where it's placed. You can see the sharp box here, it's where it is. So these are wrong handling of the linen. Then we have the most important one is about staff health, because we are all healthcare workers and we need staff health. So standard precautions is one of it, staff health, then personal hygiene, vaccination. Let's not just go to the hospital to seek for treatment when we feel unwell. That is when we visit doctors. That is when we go and check our pressures and everything. Let it make it a routine check so that now we can go and be vaccinated for prevention of, because we never know. Any patient who visits the hospital is a positive case until proven otherwise. Yeah, so let's treat all patients the same so that we prevent further infection to also HERS. Then periodical screening and redeployment is also part of it. So I'll leave it up to that point and give Mr. Kibot to continue the surveillance. Thank you.
Thank you, Sylvester. I think we are getting on. And what I like most is the controls. And that controls means you can see where the PPE lies. When everybody is in hospital, we talk about always give me PPEs. But there are many other aspects which should be addressed before we get to that PPE. It is actually among the list in the controls. So as we continue, we have other issues when it comes to IPC. As I said before, IPC is changing. It's no longer about only the standard precautions. It's no longer about only trying to mitigate issues. It's not about being just reactive. We have now gone to being proactive. Proactive means we have what we call surveillance, and we also go ahead to do what we call outbreak investigation. So in surveillance, these are new approach infection control practice. It is a proactive way of identifying and dealing with infections before it spreads. Through surveillance, gaps are identified in infection control chain. If you don't do surveillance on your catheter-associated urinary tract infection, you'll never know where you are, and you'll never know when to intervene. So progression of infection agents can be tracked using surveillance, which is very true. We can be able to see when a certain pathogen started becoming a problem, so that we can be able to put mitigations in place. So what is surveillance basically? Surveillance can be defined as the ongoing systematic collection, analysis, interpretation, and dissemination of health data regarding a health-related event for use in health action to reduce morbidity and mortality and to improve health. So here we have to underline what we say systematic. It has to be systematic. If it is laboratory-based, it has to be systematic. If it's clinical-based, it has to be systematic and with clear definition. You cannot collect the data without analyzing the data. So data which is not analyzed cannot be interpreted, and which means also cannot be disseminated. Ultimately, it means it cannot be acted on. If you have data which is not analyzed, interpreted, you cannot disseminate. I always say this data lying around every book, every file, every health record department, yet as healthcare workers do not utilize it to bring about changes in our health systems. So I think IPC is leading the way in looking at this surveillance issue so that we become more proactive in managing infections. Let us not wait until there is an outbreak that we start acting. We should be actually proactive in all this. So what are the sources of surveillance data? As I said, there are so many sources. We have admission registers in accident and emergencies, in wards, in doctors' clinics. We have all admission data. We have epidemic reporting. From time to time, you hear the Ministry of Health saying that we have a certain infection happening in a certain area. Those are epidemic reports. And that is another source of surveillance data. We have laboratory investigations, especially for IPC. The microbiology cannot be overlooked. That is where we get most of our data on infection. We have individual investigations. That is when now you go case by case. You can follow up an individual investigation to see the progression of that disease and to see the risk of that disease spreading to the next patient. We have administrative data in all our hospitals. We have data which goes to the director. We have data which goes to the head of unit. We have data which goes to all those other areas, even to the Ministry of Health. So those are all administrative data, and we can get a lot of information from it, which can be used as surveillance. There are generally two types of surveillance. Generally, we have what we call active surveillance and passive surveillance. In active surveillance, that is when you as a linked person, you as a IPC practitioner, you as a medical officer goes about looking for data yourself. You will just go actively to the lab. Actively, you can go and draw that blood and make sure it is analyzed. And that one is usually expensive, time consuming, and most organizations actually do not follow that. But although it is always employed whenever we have issues of outbreak, that's when we employ the active surveillance. The passive surveillance is the most and actually the most vibrant in our healthcare systems. In this case, we use secondary data. And secondary data means you just go and get reports from the laboratory, you go and get reports from the Central Records Department, and then you analyze and come up with some parameters which can be able to tell us where we are. So remember, there is active and passive surveillance. So you can look at this. This is an example of one of the surveillance. You can see this is what we call multi-drug resistant organism for all those years. Now, without this data, nobody can be able to see whether we had a problem in 2022. Yes, so that is actually the importance of surveillance. And this is multi-drug resistant organisms. And you can see from this data, it can drive action. It can drive change of some practices and change of some policies on use of antibiotics, on day-to-day practices in the clinical area. So benefits of surveillance data, it allows to follow natural history of a disease. In this case, if we have an outbreak of, let's say, Acinetobacter baumannii, can be able to tell us it is usually common in a certain period of time. In our case, it could be, or it is always rampant in the warm days. So if you know that, you can be able to put mitigation measures in place long before we get that Acinetobacter happening. We know the Klebsiella loves moist areas and moist seasons, so we usually prepare to make sure that during those times, we don't have a lot of Klebsiella pneumonia in our clinical areas. It also helps to monitor changes in infectious agents. You can see sometimes you get a microorganism which is not multi-drug resistant in the first place. Then within a few weeks, it becomes resistant. So what will be our role is to identify at what point did it become resistant. And that way we can be able to realize that whenever we have a certain bacteria and we don't deal with it conclusively, within a short time it becomes resistant. So that is how we are able, with surveillance, we can be able to monitor changes in the infectious agent. It also helps to set research priorities, because with surveillance data, you can be able to see that if there is a certain microorganism which is predominant in a certain unit. So that is when you can now get people going deeper to understand that organism. It supports hospital planning. In this case, the hospital cannot be wasting resources on a bacteria which is not that rampant. We can be able to see from our surveillance data that bacteria A is the one which is causing us problems and not bacteria B, C, and D. So we concentrate all our resources in bacteria A. So that is another benefit of surveillance. It also helps to monitor changes in health practices such as immunization and antibiotic use. So we said at the beginning of this that the problem which the world is grappling with is that we are running out of antimicrobial agents. So that is why it is important to make sure that this surveillance can be able to tell us where we are and where we began, to see whether we are actually progressing towards higher resistance or we are actually coming back to a better level where the resistance was not there. In setting up research priorities, this one has benefited infection prevention control units like in KNH, because we usually focus on the bugs of interest. And also what I can also add in the benefits of surveillance is that it can help us identify a new pathogen. In this case, there was a time we identified a deadly pathogen called the Candida auris, which actually, when you look at the WHO and worldwide, you can be able to realize that it is a problematic microbe. It is actually a fungi, and it causes a lot of resistance, about up to 98% resistance of all antifungal agents, and it causes very high mortality, especially if it becomes bloodstream associated. So with good research, you can be able to identify a new microorganism. Then the other tool which we talked about as an additional to IPC in the changing world is what we call outbreak investigation. Now we have had incidences where we might be having a certain bacteria being predominant in an area and sometimes causes some mortalities. What do? We really need to get to the ground and see whether where it came from, and we try and seal the loopholes where the outbreak would have come from. So this is an aspect of IPC intervention in an attempt to associate some factors to infection, because we might be talking about Acinetobacter every day. Have we tried to associate that Acinetobacter to the environment, so that if we tackle the environmental factor which is actually aggravating the Acinetobacter, we can be able to solve the problem? So that is what outbreak investigation is all about. It is a systematic analysis of all systemic aspects in patient care process. When I say all systemic aspects, it is, we look at the patient, we look at the treatment the patient has been on, we look at where the patient came from, and we look at what are the exposures around the patient, whether they were exposed to other patients who had the same disease. We look at the environment, ventilation system, traffic staff, the number of staff in the unit, how qualified are they, is there a changeover during that time when the outbreak happened. This one informs, so that if we realize that every time we have new students, that is when we have an outbreak of certain infection. So that one will inform us to make sure that before these students come in, they must go through serious training so that they know exactly what to do. And this one is in regards to what we call the IPC practices, what my colleague had gone through. So that's why outbreak investigation is becoming a component of IPC these days, and it should be actually adopted by all healthcare settings. So what does outbreak investigation involve? It involves the review of mortality rates, because we want to associate whether did this outbreak bring higher mortality than before. So this one tells you we need to deal with a lot of data. When we are doing outbreak investigation, we need to look at the surveillance data. Actually, the surveillance data is what will point out whether there was an outbreak or not. Look at the infection rates, look at the staff, antibiotic use, environmental audit, and all that, if there is any challenge. So there are several steps in outbreak investigation. We have to confirm that there is an outbreak using what? Again, surveillance data. Without surveillance data, there is no way you can confirm whether there was an outbreak. One case where a doctor might tell us that we have a problem with Acinetobacter when it is only one case in 3 months. So without good data, you cannot be able to say there's an outbreak. So we have to verify the diagnosis. We have to define what is this. If it is only one case per week, that may not be an outbreak. If it is about 15 cases in a week, when we used to have 30, that is not an outbreak, because that could be even lower than the usual level. So that's why at this point we need to have what we call our minimal line, so that we can be able to identify whether there is an outbreak or not. So from there, we need to do now what we call case finding. After we have identified that there is an outbreak, now we go to the case finding. Now in case finding, we need to go to each individual. So if it is a small unit and you are suspecting a certain bug, you now need to screen all the patients to see who is exposed. And from there, that is what we call case finding. And at the same time, as we do that, we also look at other factors, other parameters like demographic factors and the exposures, the diagnosis, and all that. Then we need to do what we call descriptive epidemiology, which is actually describing the problem. Who is affected and where and when. That is actually descriptive epidemiology. That's from there you can come up with your rates, and you can be able to now generate hypothesis. Hypothesis is just like asking yourself, where could this infection be coming from? After analyzing the environmental and all other aspects of the area, then we do an analytical epidemiology and then evaluate control measures. Now from there, you are supposed to put control measures, because by this stage, they have known a few areas where the problem could be coming from. It could be patient related, it could be environmental related, or it could be healthcare worker related. I can tell you, if you follow the steps well, you can be able to actually isolate and be able to say where the problem could be coming from. And then we focus on that. Then as we continue to evaluate the control measures, what we mean by evaluating the control measures is, if you realize that maybe it was because of the new students, whatever they come to a place, we have a rise in a certain disease. When you train the students, as maybe you gave that one as one of your interventions, did the infection it reduce? If it did, it means you are moving to the right channel. If it did not improve, it means we now need to look at another problem. Could be also taken care of by coming back to the drawing board again and trying to see where the problem could be. Then we do surveillance has to continue. Actually, after you put up the measures, we have to continue surveillance for a longer period of time. And actually, surveillance and evaluation, monitoring and evaluation goes hand in hand, so that after you put the measures and you realize that the infections have gone down, we can also be able to say, actually, our interventions were correct. This is another example of outbreak investigation, and you can see from this chart, there was an infection in 22nd July of 2022. Then nothing was done, basically, because you can see from 22nd to 1st August, it is like a week. That is like almost an incubation period. That is when you see the second case. And then the third case came. And then there has been silence. This silence will mean some interventions were put in place. Maybe anti-hygiene was aggravated. Then within a short time, people let the ball down again, and it started again. You can see at the end of it, that is by September 14th. From July to September 14th, you can see from this that the solution was not there already. So this how beautifully this outbreak investigation can actually guide us. You can see that we need to do more based on this data. Then, as I said before, you can use data to identify outbreaks. So you can see from here, in 21st of August, we had heightened cases, that is in 2021. Then we were a bit silent from there. And our baseline here is missing. Actually, we could have put our baseline at around 5, so that when we have anything below 5, we are not worried. And the baseline can always change. Then you can see in 2023, we started also again having issues. So you can, what we can see clearly, these were the COVID years when actually anti-hygiene was very heightened, when there was a lower infection. So without benefit of data, we could not have known this. And IPC is embracing use of data very well in this case. So I think with that, we are done with our presentation from this end. And the second one should be coming from our colleague in Homa Bay, because we also wanted to have that experience. We want IPC to be universal. So that's why we had to engage level 6 and level 4, so that we have that balance of IPC. With what we do there could be the same as what they do. And as I said at the beginning, all hospitals, all countries have what we call IPC programs, but they don't walk the talk. You realize that some hospitals just have appointed one nurse as an IPC person, but without resources, the program cannot materialize. So there are some hospitals which have actually tried to walk the talk. So we are going to hear from our colleague called Rogers, and I think Rogers can be able to join us now. So I can stop sharing, and then Rogers will see. We have questions, can you?
Thank you very much. Very good presentation that you have done. I think you have learned a lot, and but now I think you can be able to do questions, we have actually answered and they practice. I'll answer questions as they come, the questions as they come, but we also have Mr. Rogers Were from Homa Bay Hospital, who is supposed to be giving us a presentation so that we can also get to know from their end what it is that they do. Mr. Rogers, are you there? Mr. Rogers Were from Homa Bay Teaching and Referral Hospital. I think as we are waiting for Mr. Rogers to log in, we can have some of the questions answered. Some of the questions, there was one who had asked to be clarified on the usage of endozyme, as it has always been used as a disinfectant in the healthcare facility where they are working in. Mr. Sylvester, can you give us an answer? Thank you.
So thank you so much for that. Basically, that's a issue that affects so many hospitals. Endozyme is just like a soap, but whatever makes it so different like a soap is like it has endozyme, which basically digest the biodata, the bioorganisms in the bloodstream. So basically, endozyme will not use it as a disinfectant. It is a detergent. So by the endozyme is a detergent, not a disinfectant. So do not use it to disinfect any instrument, any surface. It is a detergent. It's just like a soap. Thank you.
I hope you have been answered. Thank you. And the next question comes from Beryl Ahome. What are some of the recommended solutions? Mr. Kibiwot, can you handle that for us, please? Thank you.
So thank you, Iris. What we usually say, first from one, but we always say that. In short, I can tell you that there is no defined disinfectant for every instrument. Depends on each. But what I can say is.
Apologies for the interruption once again. Okay. Your audio is not quite clear.
Okay, you can hear me better now. Can somebody
hear you, but faintly?
Faintly. Okay.
Now we can hear you. Yes.
Okay. So what I was trying to say is that remember, decontamination is a process, and actually we always recommend, as IPC, we recommend that the process should start in the clinical area and ends up in the central sterilizing unit, that is CSSD. So we don't want to have instruments being sterilized in the clinical area using OPA or what we call Sidex. But the best decontaminant which is available in the market is not what I can point out and say this is the best and this is not the best. It depends on every organization. What I know is in most healthcare settings, they have what we call sodium hypochlorite, or commonly referred as JIC. But as IPC, we don't recommend that as a solution to be used to decontaminate instruments because it has the effect of corrosion. So usually we recommend that when you are through with your instruments, put it in endozyme or an enzymatic detergent. And Sylvester said it is a detergent. And that detergent can be able to remove to remove the bioburden, fat, protein tissue, pus, and all that. After that happens, you are supposed to soak the instruments because by that time we don't have a lot of bacteria in it. You are supposed to put it in either sterile water or the normal clean water, pack it and take it to CSSD for sterilization. We want the processes to be two-way. Start from the ward by just removing the bioburden. The next process goes on in the central sterilizing unit. I know there are people who don't have the benefit of the central sterilizing units. If you are to use JIC, sodium hypochlorite, that is what we call it, you are supposed to just clean your instruments, insert it in that sodium hypochlorite solution for a very short time, usually about 15 minutes, then remove the equipment. Then what do you need to do? You clean using sterile water. So that is usually a very hectic process. And remember, by the time you are done with that sterile water, that instrument of yours cannot be said it is sterile. It is just clean. I hope I have answered that. So Rogers is finding challenges in sharing. I don't know, what can we do, Nelson? So maybe I can share his presentation.
Well, please, if you can share it on his behalf,
Okay.
if you have the presentation.
Document, even though Mr. Kibot would have shared another one, he has another one, but we love to continue. So my name is Rogers Were, and I'm grateful, I'm delighted to be part of this webinar today. I'm giving my presentation right from Homa Bay County Teaching and Referral Hospital, and it's inspiring to share the insights from a level 4. Remember, it's International Infection Prevention Week. We are trying to do a lot of activities here and there throughout the week, and this presentation is timely. So we're going to focus on the fundamentals of IPC in the context of level 4. And next slide. Next slide. So that is Homa Bay County Teaching and Referral Hospital. Just a picture of the new renovated outpatient center. Next. Next slide. I'm sorry. Now, Homa Bay County Teaching and Referral Hospital is just a level 4 facility within the Nyanza region, and it serves like 8 sub-counties within the Homa Bay County, within the Homa Bay County. And it started in 1969 as a dispensary. Then today it's in the process of upgrade to level 5. We are trying. I think someone should clap for us. Currently, we have a bed capacity of 300, often both inpatient, outpatient, and post-discharge services. We have ICU, maternity, radiology services, and we work in collaboration with the partners. And among them is LVCT, MSF, CDC, among others. So, next slide. Yeah, so what about our IPC activities within the hospital? So we have an IPC committee, which actually for now reports to the hospital CEO. We have our director of nursing services as acting as the chair, and the deputy is acting as the overall focal for the hospital. And we also have our quality assurance officer, part of the team. Our public health officer is the secretary of the committee. And we also have a departmental link person we call focal persons here, who help, who act as a link within the departments they come from. So recently, we've been trying to engage even the top management, the procurement, the security officers, because we realize they are supposed to be part of what we discuss here. Next slide. So why IPC committee? IPC committee is basically here to promote patient safety. We are carrying out audits like hand hygiene, waste, linen management. We do training of healthcare workers and other support staffs. We do support supervision. We do hospital IPC policies. We try to reduce occupational hazards associated with healthcare, and we do antimicrobial stewardship, rational use of antibiotics, and also ensure compliance with stipulated IPC guidelines. Next slide. So this is just a reminder that we are celebrating the International Infection Prevention Week this week, and APIC came up with those 5 main hand hygiene, cleaning and disinfection, vaccination, PPE, injection safety. as main areas of focus as far as fundamentals of IPC is concerned. But basically, these are just part of the standard precautions that we're used to. They just pick the 5 for the purpose of this year. Next slide. So what are we trying to achieve? So the World Health Organization defines IPC, or infection prevention and control, as a practical, evidence-based approach preventing patients and healthcare workers from being harmed by avoidable infections. And you say it's unique in the field of patient safety and quality of care, as it is universally relevant to every health worker, patient. That is the World Health Organization definition, and as at this year, 2023. So why are we so much concerned? As you can see, IPC is practical, evidence-based, and it covers both patients and healthcare workers. All of these people are a concern for IPC, and it's unique. So the U.S. Center for Disease Control and Prevention identifies 1.7 million hospitalized patients annually acquire healthcare-associated infections. So healthcare-associated infections, I know most of us are familiar with that word. It used to be called hospital-acquired infections or nosocomial infection, but studies prove that these infections can be acquired in any setup where care is provided, including home-based care facilities, and not only in the hospital. So that is why we nowadays call them healthcare-acquired infections. And a lot of people die. And as you can see from the data given by CDC, while we say that these people being treated for other health issues, and that more than 98,000 patients die for healthcare-associated infections. Next slide. Next slide, please. So today, we're told that every 100 patients, out of 100 patients in acute care hospital who are hospitalized inpatients, 7 patients in high-income countries and 15 patients in low and middle-income countries like our country here will acquire at least one healthcare-associated infection. So healthcare-associated infection is categorized in several categories. I know most of us are familiar with them. We have the CLABSIs, we have SSIs, we have VAPs. At least one of them. These patients who are hospitalized, you realize that in low and middle income countries, 15 patients will acquire at least one of them during their hospital stay. So on average, 1 in every 10 affected patients will die from healthcare-associated infection. That is according to the report released by WHO in May 2022 report, when they were giving a report on COVID-19. So, however, we realize that very little information is available about very little information about healthcare-associated infections is available in Africa and Kenya, for that matter, because studies showed that there is little support for surveillance. Mr. Kibu talked more about surveillance, and he also said there is lack of action. So most of facilities they are willing to come up with IPC committees and IPC champions, but support in terms of financial and other aspects is a big challenge up to now. So according to a study that was conducted to get truth, this is one of the studies I realized here, the total number of healthcare-associated infections were 52, and infections in 41 cases, of which 24 cases were culture-proven bacterial healthcare-associated infection, 6 cases and more than 1. So this is a study that was done in Kenya and at Gertrude Children's Hospital, and they realized that out of 41 cases, 52 of them were cases of healthcare-associated infection. So this means it's an area that is a major concern for us. Next slide. Next slide, please. Next. Next slide. Okay, I'll continue. So the fundamentals of IPC, next slide. So the fundamentals of IPC. Next slide, please. Fundamentals of IPC. For the purpose of this presentation, we are going to cover them in form of, we have hand hygiene, we have device-related infection prevention practices, we have cleaning and disinfection. My colleagues from KNH covered cleaning and disinfection, injection and sharps safety. We have waste management and use of PPEs, and vaccinations. Next slide, please. Next slide. Next. Okay, so just to start with hand hygiene. Here at our facility, we try to ensure that we adhere to the 5 moments of hand hygiene as stipulated by the World Health Organization, and we have hand washing points and hand hygiene. We understand that it's not just about hand washing. Hand hygiene entails hand rubbing or use of alcohol-based hand rub, use hand washing, and also surgical antisepsis. So I don't know whether I lost. Okay. Thank you. So we are talking about hand hygiene, and we are saying hand hygiene is not just hand washing. Hand hygiene is very popular for hand washing, but it's not just hand washing. It entails use hand rubbing, or what we call use of alcohol-based hand rub, which is recommended to be between 65 to 95% alcohol, with alcohol, which would have at least 65 to 95% of alcohol content. And we also do surgical antisepsis, which is done in theaters. So we have available running water in sinks and soap for proper hand washing. That is a way we are trying to support hand washing. And in terms of alcohol-based hand rub, we try to avail alcohol-based hand rub, especially where a lot of patients are being seen at our consultation rooms. And because we know that studies are showing that use of alcohol-based hand rub is, if the word superior was to be used, I dare say that, except for cases whereby you are eating when your hands are visibly soiled, or when handling high infection like Clostridium difficile, and of course, yeah, those are some of the reasons, the circumstances when you are supposed to do only hand washing. When your hands are visibly soiled, that is the keyword. But when your hands are not visibly soiled, and when you are dealing with patients in a busy setup, it's advisable to use alcohol-based hand rub. And studies have not shown the number of times you can use alcohol-based hand rub to change to hand washing. So there are a lot of questions that now that I'm moving from this ward, this department, I have 30 patients. I'm moving from patient 1 to patient 30. What do I do now that there is no water in the tap, but I have alcohol-based hand rub? The answer is continue with your hand hygiene using alcohol-based hand rub unless your hand is visibly soiled. There is no study that is showing that after sanitizing twice or 3 times, you have to shift to hand washing using soap and water. If anything, there are all those disadvantages of soap and water. Soap and water, it takes time between 40 to 60 seconds. You will need to dry your hands, and use of alcohol-based hand rub, you won't need to dry your hands. So it has all the advantages, except for the reasons we said. After visiting your toilet, when you want to eat, yeah, those are some of the reasons. So in efforts to promote compliance with hand hygiene, especially during ward rounds or drug rounds, which is done by our nursing officers, we have placed sanitizers after every 3 beds, because we realized that people could go for round between first patient to the last without properly adhering to hand hygiene measures. So that is why we ensure that we have our alcohol-based hand rubs are available and very convenient and take a short time. The alcohol-based hand rub is just 20 to 30 seconds. Within 20 to 30 seconds, you are done with your hand hygiene, and it dries, and you can move to a next patient. It will protect you, because soap studies show that soap has very little, if any, antimicrobial activity. You can use soap to clean your hands, but it does not offer you better protection. So we also have use of an app, which is just to pick from to steal from the presentation of Mr. Kibiwot on A Changing World, Mr. Sylvester, I'm sorry. We nowadays use, we have apps that can detect hand hygiene compliance. We can use UV light, you can use UV gels. All these ones are there to check whether your hands are clean. Yeah, next slide. Next slide, please. Next slide. Yeah, as you can see, that is just a picture that was taken in one of our wards. You can see the first bed on your right, there is a sanitizer tied there. And if you move to the next one, there is a hand washing sink. Or the other side is also we also have a sanitizer tied there. Next slide. Next is clean is the disinfection. So for the contamination processes, we are trying to ensure that we follow the cleaning and disinfection or sterilization protocol. We ensure that for all our critical, non-critical, or semi-critical medical devices, we follow the WHO stipulated guidelines on decontamination. The word decontamination is the one that covers both cleaning and either disinfection or sterilization. So we also do surface disinfection using the recommended solutions. We have detergent disinfectants, and we also have detergents even though World Health Organization recommend use of detergents in cleaning, it does not recommend use of disinfectants during cleaning. But there are those solutions that are detergent disinfectant, especially the quaternary ammonium-based compounds, whereby you need only one step, you don't do 2 steps. But it has disadvantages sometimes because you need only to clean an equipment, then take it direct to CSSD. You don't have to repeat yourself from cleaning, sterilization, disinfection, and then sterilization. After cleaning your instruments, they should go straight to the CSSD. Then routine cleaning is also done every day. A terminal cleaning is a cleaning that is done when your patient is discharged, or when a patient dies, or when you're transferring your patient. You do terminal cleaning. We do schedule cleanings. When we wash our curtains, we wash our walls. And we are trying to use a cleaning trolling with 2 or 3 bucket system. 2 bucket system is advocated for, especially when cleaning. We're using detergent and water. But when doing disinfection, you are supposed to use 3 bucket system. We're also trying to use color-coded buckets, wipes, and mops. Next slide, please. Next.
So, Mr.
Okay,
Rogers,
so now,
this is your presentation.
Yes, yes.
It is not able to the one that you are saying that the latest one.
Yes,
is
yes.
not really working well on our side. So that's what we have downloaded here.
Okay,
So
okay, it's this one.
Can you see
Yeah,
it?
this one. I'm seeing it. I'm okay. I'm very much okay from my side.
Okay, so when you realize that where were you?
Yeah, I'm at the 2 bucket system. There's a diagram there where we are showing the 2 bucket system for cleaning. Yeah, and we're saying that. Yeah, okay. Yeah, there. Think no.
Yeah.
No.
These are 2 buckets now. It's here.
There's 2 bucket system there. Okay, that one. Okay. Thank you. So just trying to say that in this bucket, there is 1 bucket for drying, which has clean water, and the other one has a detergent. So when doing cleaning, that means you're doing cleaning in areas that are not high risk, low risk areas. When you're doing cleaning or mopping, you can use 2 buckets. And where disinfection is involved, where you need to use your chlorine or all detergents, you're supposed to use 3 buckets so that you don't mix your detergent plus your disinfectant plus your clean water. Next slide, please. Next slide. So we said we are going to discuss this in several bundles, and the first one we've talked about the bundles and hygiene. We talked about cleaning, disinfection. We have now device-related infection prevention practices. So for the purpose of this presentation, I'm going to talk about a study that was done in 2019. And you can see IPS is the Infection Prevention Society. We have NIVAS, National Infusion and Vascular Access Society, the British Association of Urology Nurses, and the Association for Continence Advice. So they came up with a document called Improve Collaborative in 2019. And this document came up with what we call high impact interventions. They were trying to look at how can we approach problems, as you can see. So these high impact interventions were developed using evidence-based guidelines. We said IPC is evidence-based, and they're also using care bundle approach. Mr. Kibut touched it slightly, but the care bundle approach was also used an evidence-based practice to come up with ways in which they could prevent infections related to urinary catheters and vascular access devices. For this case, I'm talking about the peripheral intravenous catheters, that is the IV lines that we're used to, and also the central venous access. So this team were trying to come up with ways in which they could prevent urinary infections related to urinary catheters, cautis, and the vascular access devices infections. Those infections that are associated with peripheral intravenous catheters, that is IV lines, the ones we use, cannulas, and also the central venous access devices. So they use the care bundle approach, and this document is provided in this website I've provided here. There's a very beautiful document about that. Next slide. Next slide. So we are talking about urinary catheters as the first one, and as you can see, urinary catheters. And we're saying indwelling urinary catheters account for 70 to 80% of urinary tract infections and a major cause of bloodstream infections and sepsis. And the risk of catheter-associated urinary tract infection or CAUTI increases by 3 to 7% each day the catheter remains with the patient, especially in low and middle income countries. These are not my words. These are words from the World Health Organization. This is each and every day that a patient has a catheter in situ. We call them catheter days. Any catheter day, the risk of infection increases by 3 to 7%. So this means we should minimize the number of days that the patient spends with the catheter. So we say that all urinary catheters.
Sorry, Rogers.
Yes. Hello.
Hello, Roger. Sorry for the interruption. Because of the interest of time,
yes,
I would ask you to be a bit faster.
Faster. I'm trying to be faster. Okay.
Thank you.
Okay.
Thank you, Rogers.
Let's continue. So as you handle catheters, you must ensure that you perform the hand hygiene, especially moment 2 and moment 3. You must adhere to all of them. And when you are collecting the urine from urine bags, ensure that you use each and every patient as their own collecting jars. You don't use one collecting jar for every patient. Next slide, please. Next slide. Next slide. We used to say that we are supposed to be cleaning the periurethral areas when dealing with these catheters. Next slide. So we're vascular access devices. This is where we are talking about the peripheral vascular access devices and the central venous access devices, the IV cannulas that we use. So we say that vascular access devices associated bloodstream infections are one of the most device-related healthcare associated infections and are often preventable, according to that study done there. And what are the sources of these infections? So the practitioner's hands can be direct contact. The patient's skin can be dirty. That can lead to extraluminal infection. Maybe the tubing infiltrates and maybe contamination through indirect contact. Why we are taking care of where we are focused about vascular access devices, because there are risk of extravasation, thrombosis, migration, phlebitis, and medical device-related skin injuries if you don't manage it properly. So the word is right line at the right time for the patient. Next. So according to a report that was released by the World Health Organization in 2023, healthcare-associated bloodstream infection are often linked to peripheral intravenous catheters, which are the most common form of intravenous access used worldwide. So this is a study that was done by the World Health Organization. This is why we must emphasize this and so loudly. So when using blood products, for instance, for infusion, it's advisable that you change the IV tubing and connections immediately after completion of the infusion or every 12 hours, whichever comes first. So it means when you're doing blood product, if you choose your blood will run for 12 hours, after 12 hours, you must ensure that you change the tubing. Next slide. Next slide. Next slide, the interest of time. Next slide. So there is what we call the care bundles approach in management of CAUTIs, and it's just a use of appropriate indication. Don't insert catheters when they're not indicated, and use a septic insertion, daily care and documentation, and please let's do documentation. Whenever you go for your shift, ensure that you document about a catheter, an IV line, and score them. There is what we call VIP score for your IV lines. So if it's not favorable, any score above 2, you're supposed to reset the catheter. Next slide. Those who will be able to visit the site, the website that I shared, these documents are there about care bundles that were brought in with the high impact interventions. They are just the same things. Next slide. Okay, so that is just an example of what we do here. As you can see, that urinary catheter, it's below the floor, and it's above the floor, sorry, and or below the bladder to prevent entry of uropathogens. And their IV cannulas is dated, and we are supposed to be removed within 72 hours. I was looking at the UK version; they can maintain a proper. Okay, next slide, please. So, how can we prevent these infections? These infections associated with IV cannulation and the rest. So there is what we call TIVOS, timely appropriate IV to oral switch in antibiotics. And this is why I was trying to compare it with its impact on management of device-related infection prevention practices. So this is The National Antimicrobial Intravenous IVOS criteria for early switch contains 24 IVOS criteria categorized in 5 sections. This is where we are trying to ensure that within the shortest time possible, we convert a patient from IV drugs, medications to oral medication. That is what we're saying, TIVOS, timely appropriate IV to oral switch when there is indication. This patient is not vomiting the last 24 hours. The patient has improving clinical symptoms. The patient has within 48 hours, the patient has been improving. You change to orals. And why is it important? Next slide. Why is it important? Next slide. Benefits. Next slide. So timely IV to oral switch is very important to the patient, to our healthcare team, and also to the continent. We studies showing that when patients are shifted from IV medications to orals, the time that they spend to be nursed within the hospital is reduced, and there is also reduction in the what we call the length of hospital stay. And there's a study, an interesting study that was done, use of ciprofloxacin IV and oral. And when comparison was done, they realized that 7 days of IV ciprofloxacin 400 milligrams 12 hourly compared to ciprofloxacin 500 milligrams oral for 7 days. There are 67 grams of carbon were produced when using the IV, and when using the oral, it was just 1. So that shows that the IV medication can lead to a lower carbon footprint. The oral antibiotics have a lower carbon footprint. Next slide. Next slide is about injections or sharp safety. I can't say more because my colleagues talked about it, but in our setup, we try to ensure that our sharps our sharps boxes are emptied when they're 3/4 full. Next, about waste management. We use color-coded pedal bins in all our departments, and yes, we try to ensure that our wastes are segregated appropriately as following the guidelines by the World Health Organization. The World Health Organization, as you can see, is trying to advocate for at least a 2-bin system for the setups, lower facilities like the ones below level 4, level 3, and below. They may be having challenges in getting the waste bins. So the World Health Organization is advocating for at least a 3-bin system where you have the sharps and you have one for general waste and another one for infectious waste. And there was when we last started the webinar, there was the Committee for Environment was coming up with a new guideline. I know they will share it soon when it's ready. Next slide. Next slide. So about vaccination, we are just like any other facility. We are trying to ensure that all our health workers are vaccinated against hepatitis B, sorry. And COVID, we are seeing COVID cases have slowed down, but it's still there with us. So still people can benefit from COVID-19 vaccination to prevent severe infections. Next. So is IPC a small fish in a big jar or a big jar in a small fish? Well, so these are some of the challenges we face because we realize that most of the administrations or in lower level facilities look at IPC as just a small fish in a big jar. While all of us know that IPC is a very big fish, a very big fish being seen as small jar because there's more that should be done to IPC than meets the eye. So what are some of the challenges that we face? There is inadequate support and motivation. There's a lack of approval of budget, the shortage of staff, so members cannot attend their meetings regularly, and lack of funds to get IPC supplies is also a challenge. And the top management not able to show up most of the time because they are busy schedules. Next. So what next? What next? So we are calling for what next? We are calling for strengthening and support for IPC right from top management because, as Mr. Kibiwot said, we need support and financial support to ensure that all IPC guidelines are adhered to. So we also ensure that we provide education and benchmarking for IPC team, and we also conduct a periodic supportive supervision, peer supervision, and also avail job aids and posters in IPC, support and promote more rigorous surveillance and IPC research. Mr. Kibiwot talked more about surveillance, and it's very important, very key for the current IPC, and update IPC guidelines according to evidence-based practice. So more awareness on IPC is needed right from the top. That is the message. And before I leave, I know you are tired. I know our presentations will be here. but I will leave you with the words of Rumi. He says, I know you are tired, but come, this is the way. Thank you so much.
Thank you very much, Mr. Rogers, for your presentation. That was well done. I think now we can look, even you can see the claps that are there for the good presentation. I think now we can go back to the question. Time has lapsed, and we are almost at the end of our webinar. So we shall check on the questions that are there. I once attended a training where the facilitator said after disinfection of instruments with chlorine, they are not supposed to be rinsed with water, but be taken for sterilization.
So let me clarify, allow me to clarify what I said. I did not say you rinse with water, then you're able to use. I said that is just the first process of instrument reprocessing. So after you are done with your chlorine and your take it to CSSD for the next process of sterilization. So we don't want you to be using chlorine, then clean water, and then using the pipe. So let it be very clear. It has to go through the instrument reprocessing to the extent of sterilization. I hope I have answered that question well. And in fact, the sterilization process starts from the water, half of it starts from the water, and the other half ends in the central sterilizing.
Thank you, Kibiwot. Our next question is sulfanions a cleaning or a decontamination agent? It's common in NICU, neonatal intensive care unit.
So what I can say about this, it is a surface disinfectant, what we call sulfanions. We usually don't like using the trade names, but I think it has some quaternary ammonium compounds in it. So it is a good decontaminant. It is actually a good antiseptic to be used on surfaces. If you use it in NICU, that is still okay. It is just like the chlorine-based solutions.
Not able to hear.
So that is what I've just clarified. I said the whole process must end up in sterilization. Whichever way you use, most of us use the endozyme at the beginning. That is actually a detergent just to wash. Then after rinsing, before the onward process. So I think I have answered that one several times. So that one has been handled. I said that is the first process of instrument reprocessing. So that one, actually, I think that one has been answered already. So I think what Joseph is talking about is what Roger has mentioned about the care bundle. We need to have what we call clumsy care bundles. That one will take care of all that. And I don't know whether the ministry has rolled out the care bundles that way, but you can get a lot of help from the website that Roger has provided. So that one falls under the care bundles. And we encourage each hospital to do it independently. Let us not wait for Ministry of Health to roll out the care bundles. This one, I don't think there is any tangible evidence to show that there is a less or more risk when you dilute to prepare the injectables either next to the patient or at a preparation room. It's always a good practice to prepare the injectables at a place further away from the patient, because actually around the patient environment is usually very contaminated. But when we talk about evidence, I have not seen, but maybe they are available there. We need to just look at it for it. So about the first question, whether that was about catheterization, do we use tap water? So I don't know whether you meant using tap water during catheterization, the contamination agent. So that one should never be used. Actually, what we just need to use is chlorhexidine. If you say, oh, to secure the catheter, I think it is to inflate, to balloon the catheter. We usually are supposed to use only sterile water, distilled water, not normal saline, because normal saline can actually corrode that rubber and make it fast, and sometimes it can form some deposits. So we always recommend sterile water. No, it's not advisable to remove the catheter. What comes out here is usually the choice of the catheter. We are supposed to use the silicone catheter, not the Foley's catheter, because silicone catheter has less chances of attaining the blood clots or getting infection. So that, because we remember these are patients who will stay with that catheter on a long-term basis. So we are advised to use silicone catheter as opposed to the other kind of catheter.
Yes, apologies for the interruption.
Yes.
I can see in the interest of time, we are past 30 minutes from time we're supposed to be ending. Maybe you can pick 2 more questions, and then we can address the other ones much later. You're still faint. We cannot hear you.
What the latest WHO standards as per hand hygiene with at least 70% alcohol concentration? Our president or just said hand washing has said a lower rate when it comes to bacterial and viral prevention in the disease prevention process. Kindly elaborate.
So the recommended is usually, as you have said, it should be at least 70% alcohol. You find that most of the ones which are available are between 70 and 80%. So I think that one is still appropriate. Then somebody talked about the ratio. I think it's the ratio of decontamination of sodium hypochlorite. It is usually 1 part to 6 parts. So that is the universal.
We are very grateful for having been with us and having been very patient. We are half an hour past our time that we're supposed to have finished. What I can say is let us practice what we have learned today, and we are going to see that we are going to move a great mile from where we are. Because 1,000 steps starts with one. So let us start with one where we are, and then we shall see the benefits of them all. With this, I take this opportunity to thank the presenters very much because of their presentations. They have educated us very well. And for the research team that has made it possible for us to be able to give this webinar and teach everybody all over the country on the same. So with this, I take this opportunity to end our presentations and tell you to have a good evening, and let us make IPC part of our lives. And you shall have no HAIs where you are. Thank you very much. This has been Lucy Kanyi, your moderator from IPC, Kenyatta National Hospital. Have a good evening. Bye.
Thank you, Lucy.